Hello, friends. We are now going to dive into a specific skin cancer, and that is malignant melanoma. For the lay public, this is what people think of when they think of skin cancer. They think of malignant melanoma, and this is, although not by far not the most common skin cancer, it is the most deadly skin cancer, and so this is really what people think of when they think of skin cancer. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right hand corner, and it should link you up. If you could consider chipping in $1 a month, a little bit goes a long way to help keep these videos free and coming. If you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, treatment plan, things that will come in handy for you. Both for clinical practice, impressing your attendings, and for step 3, because you have those clinical case scenarios which are not multiple choice. So thank you very much in advance for your consideration. We're going to start with a vignette. Now, you probably already know the diagnosis because it's the topic of this video, but you can pay attention, keep an open mind to this vignette. We have a 41-year-old white woman presenting with a dark, irregular, pigmented patch that she noticed 6 months ago on her left lateral calf. It has been increasing in size for at least the last couple months. She reports approximately 8 sunburns in the past and uses tanning beds about twice per month, which she's been doing for the last 15 years. Family history is positive for melanoma in her uncle. On physical examination, approximately 60 normal appearing nevi ranging in size from 2 millimeters to 5 millimeters, with symmetry, uniform brown coloration, and regular borders are visible. The pigmented lesion on the left calf is asymmetric along the 2 axes, measuring 1 centimeter by 0.8 centimeters, is deeply pigmented with several shades of brown, and has a jagged border. The popliteal and inguinal nodes are not clinically palpable. So we've got a woman coming in with a new skin lesion, a pigmented skin lesion, and she's got a history of sunburning. You should always, and anytime you've got a patient coming in with something on their skin, you need to get a good dermatologic history, and that includes a family history of skin cancers. How much sun exposure are they getting? What do they do for work? You know, they might not sunbathe, but if they're a farmer or if they're a construction worker or if they do anything outside frequently, they're certainly predisposed to overexposure to the sun. So these are things that you'll want to ask. And so the most likely diagnosis here is malignant melanoma. And that's just based on the clinical appearance. We're going to see a rule called the ABCDE rule. It's not really a rule, it's just kind of a rule of thumb. And it's helpful for distinguishing more suspicious lesions from the more benign and non-suspicious nevi or moles. What do we do then for this patient? What's going to be the next step? This is going to be asked on the USMLE. The best next step is an excisional biopsy. You can't diagnose melanoma just on clinical appearance. You don't diagnose any cancer on clinical appearance. So you're going to need to get a biopsy, and we do an excisional biopsy. Typically, that's reserved for smaller lesions. We can just take the whole thing out. Obviously, if this was, some massive lesion, and then melanoma would not ever fall into this category. If it were a massive lesion, you could do an incisional biopsy. But excisional biopsy is done for skin lesions. You could do punch lesion, but the idea is we want to try to kind of take it out because this is something that's going to need to go. So you do an excisional biopsy. You look at it under a microscope and you make your definitive diagnosis. You can also do some prognosticating at that point as well based on if it is melanoma, how far are the abnormal cells invading the dermis or hypodermis, if at all. So malignant melanoma is a malignant neoplasm derived from melanocytes. You should know this if you watched my overview of skin cancer. I would suggest doing that if you haven't already, because we're just building off of it. The benign equivalent of a malignant melanoma is a nevocellular nevus, otherwise known as a mole. As far as epidemiology, the American Cancer Society estimates that almost 100,000 cases will be diagnosed in the U.S. About 60% of these cases will be in men, probably due to increased occupational exposure, farming, stuff like that. Incidence is rising, so that's problematic. Although, however, the incidence is rising, the number of melanoma deaths is not. So that's a good thing. That's probably due to increased awareness, earlier detection, and just better clinical practice as far as excising these. Probably not due to those new chemotherapeutic drugs, because the number of people that get caught really late on is pretty low. We haven't really used those chemotherapeutics that much, but I'm sure that might contribute to it a little bit. As we talked about in the overview of skin cancer, whites are predisposed to pretty much all of the skin cancers more than other racial groups. Whites actually outnumber blacks 20-1, which is really staggering. Only 1% of skin cancers, but a vast majority of skin cancer deaths, about 75% of skin cancer deaths, are from malignant melanoma. Malignant melanoma peaks in around the 5th to 8th decade of life, median age of about 63, but it is a significant cause of cancer in young people, especially these young people that are constantly out in the sun, constantly sunbathing. It's a really big problem. Remember to take into consideration the patient's occupation as well as lifestyle habits. Malignant melanoma is the most rapidly increasing cancer in men. That's really surprising too. And the second most rapidly increasing cancer in women, next to lung cancer, and that's because more and more women are smoking. At least, in the 70s and 80s, a big lag time there with cancer. So risk factors include chronic sun exposure and sunburns. With melanoma, it tends to be, in general, with the more common forms of melanoma, it tends to be due to periodic intense sun exposure as opposed to chronic low intensity sun exposure. So really, then you're thinking about those tanning beds, because you get a tan by going into these tanning beds 5 to 10 minutes per session, maybe once or twice, maybe once a week or so. I used to do it when I was in college, and I quit once I got to medical school and learned how bad of an idea that is. But in any case, it's the high-intensity exposure to UV radiation that's really behind this. So, 20, 30 years down the road, these people are still going to be at higher risk for melanoma. Dysplastic nevus syndrome, an autosomal dominant disorder, which we're not going to go into. Familial melanoma, that's why it's important to get a family history. These people are probably not diagnosed with familial melanoma, so knowing if grandpa or aunt or parent had melanoma can be really useful. Just remember that's a P16 loss of function, so they're at risk for melanoma as well as possibly other cancers. It can also arise from pre-existing nevi, so that's important because people who have a lot of nevi to begin with are probably going to be at an increased risk, because any of those nevi can go on to become melanomatous. As far as gross appearance, this is one of the most important things I want you to get out of this. A, B, C, D, E. And you probably learned it in med school, but we're going to cover it again. A stands for asymmetric. Normal nevi are symmetrical, more or less. Irregular borders. The borders should be smooth. With melanoma, they tend to be jagged. C stands for color, variegated color, different shades of brown, maybe some black, maybe some red, different colors. Normal nevi are pretty confluent, usually brown. D for diameter, more than 6 millimeters, you should really have your red flags up. So that's about the size of a pencil eraser. And E for evolving, changing. So if you look back at our patient here, let's see, she had the evolving, she had the asymmetry, she did have regular borders, and then she had the size. So you're not always going, this says, sorry, she had the jagged border. Okay, so the regular borders were on the other nevi. That's good. She did have the jagged border. So she actually had all of the A, B, C, D, E. Not all patients will. So, if you're talking, they got 3 or 4 of them, that's enough to do a biopsy. They don't have to have all of them. Some will, but not all of them. Okay, go back here. All right, so this is the estimated cancer incidence for melanoma by country. And, if you look at it, it's basically a map of where white people are. So, all of Africa, South Africa is big. There's a white population there. Australia, Western Europe, Russia, United States, going in kind of to South America. Now, why some of these other countries that don't have a lot of white people? Probably because they are kind of at the equator. So, it's not perfect, but for the most part, this follows white people. There are 5 different kinds of melanoma that I want to bring up, but if you're taking step well, any of the steps really. You don't really need to know all of these, so I put it in here for completion's sake. There's just a few points I want to bring up, and I do cover these in the overview of skin cancer section. The superficial spreading melanoma is the most common, 60 to 70%, tends to show up on torso of men and the legs of women. The nodular melanoma is in slightly older people, middle-aged, 50s. This tends to show up as it's a nodule, usually reddish brown, and it often ulcerates pretty quickly. So this tends to have a poor prognosis, and the reason it has a poor prognosis is that while the other melanomas tend to spread horizontally and then vertically, this one just goes right in vertically. And so, as we're going to see, the big prognosticator for melanoma is the depth of invasion. So because this invades vertically so quickly, it tends to have a poor prognosis. Lentigo maligna melanoma arises from a lentigo, which is a horizontal distribution of melanocytes that causes a kind of pigmented patch. And so this tends to occur in older people. It's very slow growing, pretty good prognosis. Acrolentiginous melanoma, very important here that you know that this tends to occur in people of color. This only makes up about 5 to 10% of melanomas overall, but in African Americans, it's around 70% of melanomas total. So this tends to show up in the soles, palms, and nails. The nail is an interesting place for a melanoma to show up. I'll show you a picture of that. Why the soles and palms? Probably because they're less pigmented than the other parts of the body. If you look at the hand, of a person of color, their palms tend to be about the same color as white people. So. And then the amelanotic, you're not going to be asked about this on the USMLE, but I just included it in here. It tends to have a poor prognosis because when we think of melanoma, something that shows up, something that's easy to diagnose, we think of a brown or a black lesion. This is a lesion without pigmentation. A lot of times it just looks like a pimple. But a pimple that doesn't go away. But it's often not something that's going to bring people into the doctor's office. So unfortunately, by the time this is diagnosed, if it is at all, it's usually too late. Remember, all prognoses depend on the depth of invasion. One more thing I wanted to bring up is the mucosal melanoma. Only 1.3% of total melanomas, but this is an important one, especially for women. They can get melanomas on their vulva. So if you're an OBGYN, very important to keep that in mind when you're doing examinations. Look for dark lesions because this can occur down there. It can also occur in the oral mucosa. It can happen in the anorectal area. So you can get melanoma in those areas. And then I put some specific locations that these tend to occur, but really they can occur anywhere. These aren't the only possible locations. So the symptoms of malignant melanoma often asymptomatic, but occasionally once they start invading enough, they can become pruritic. Patients will often notice a new, what they'll call a mole, or it can be discovered on physical examination. As far as the physical exam, you want to do a whole body skin examination. So if they do mention one focus of a new mole, you want to look everywhere because patients who have more than 50 nevi are at greater risk, significantly greater risk, even if those nevi are benign appearing. If they've got large nevi, again, that points to possibly some kind of congenital issue that they may not know of, even if they are otherwise benign appearing. Also, the ugly duckling sign. This is something that my attending dermatologist threw at me when I was in medical school. I thought it was an interesting term. But basically, it just means that the lesion in question looks different from all the other nevi. It tends to be, for some reason, that people who have a lot of nevi, all their nevi look the same. And it might be different from, another person who has a bunch of nevi, but they all kind of have the same phenotypic appearance. But when a nevi or a nevus becomes a melanoma, or if they get a melanoma, it's going to look a lot different than all those other ones. So that's kind of a giveaway, the ugly duckling sign. And then remember ABCDE, that should be ABCDE rule, not sign. Or signs, I suppose. Ulceration or bleeding of the lesion question, very strong sign of melanoma. It doesn't hurt to look for lymphadenopathy and constitutional symptoms, but they are rare at presentation. So for diagnosis, it tends to be first suspected clinically based on appearance. You should always ascertain the family history and lifestyle habits, occupation, etc. The dermatologist, if they look at this, they'll probably do a dermatoscopy. You're not going to ever do this. So as far as exam purposes go, the means of diagnosis is an excisional biopsy with margins. That's the best initial test, and it will also yield a definitive diagnosis. Differential diagnosis, there are a few different things here. I'm not going to go into all of them. Benign melanocytic nevus, that's just basically your mole. Remember the A, B, C, D, E. Moles will be negative for most of those things. Usually they're smaller, uniform color, more symmetric, regular borders. They never ulcerate. Basal cell carcinoma, remember going back to our overview of skin cancer, this is more pearly in appearance. It tends to be less pigmented, although it can have some pigmentation, and that can draw some confusion. And so in those cases, in any case where you suspect a basal cell carcinoma, you're going to biopsy it, and that should give you your definitive differential right there. Remember also that basal cell carcinomas tend to have telangiectasias. Actinic keratosis can be pigmented as well. However, actinic keratosis is rarely a solitary lesion. A lot of times patients will have multiple. There tends to be less pigmentation and more keratinization and erythema. They can also be painful. And then seborrheic keratosis, it kind of looks like, you know, they took some piece of something and stuck it on their skin. So like, you know, I don't know what you could stick on your skin, but it's very, it looks stuck on, it's waxy, it looks like a wart almost, and it can be pretty keratotic as well, which you can imagine based on the name. So this is an example of a malignant melanoma. Particular here, this is a superficial spreading melanoma, but it also has what's called regression. So regression is, this is probably not, 5 different melanomas. What probably happened here is that there's some regression, and regression is just the immune system killing off the cancer cells. That doesn't mean that they don't have cancer, they obviously do, but just know about regression, that can be there. That area still needs to be excised, obviously. This is also a superficial spreading melanoma, pretty classic appearance, but if you're not looking closely, you might not notice this pigmentation here. Again, you might not have this like red or blue color, but different shades of brown can be a sign of melanoma. This is an amelanotic version of a nodular melanoma. So if you were to actually see this three-dimensionally, it would pop out at you. Notice too here that there's also some ulceration. This is also a nodular melanoma, much more pigmented, a little bit smaller. Nodular melanomas are the only ones that aren't flat, so it's what gives it its name. Remember, this one has a poor prognosis because it grows vertically so quickly. This is a lentigo maligna melanoma. Notice the lentigo here, lentigo, and then this is the melanoma coming off from it. Again, this is more in older people. This is an acral lentiginous melanoma. It's occurring on the palm, as you can see here. And this one tends to occur more in people of color. And this is a subungual melanoma occurring underneath the nail. When melanomas occur underneath the nail, they often occur like this. This is called Hutchinson's sign. And it's basically pigmentation from the nail bed to the tip of the nail in this sort of longitudinal appearance. Microscopically, you'll see nests of pale staining melanocytes where they don't belong. Remember that melanocytes belong at the basal layer of the epidermis, the stratum basale. And I'll just tell you this, for the USMLE in general, if you're taking step 1, you need to look at these slides, you need to understand what you're seeing. If you're taking step 2 and 3, you're not going to look at any slides, but you do need to know like a histology or a pathology report. So if they tell you nests of pale staining melanocytes in the dermal layer, you need to know that that means malignant melanoma. Even though you're not seeing the picture, you need to understand a description of the histopathology. So melanocytes should be here. This is stratum basale down here, and you've got your Reitz ridges and your dermal papilla here, and these are melanocytes right here. Melanocytes can also be here. They're in the same position, there's just a lot of them, and that's okay. So this is actually a junctional nevus. So this would be sort of like your mole. But melanocytes should never be up here. Look at these melanocytes, little nests of melanocytes in the stratum granulosum. Should not be there. This is an early, well, we can't really tell because we can't see the dermis, but this is probably a fairly early melanoma. And they definitely should not be down here. So here you see that there are melanocytes invading not only in the epidermis, but all the way down to the reticular dermal layer. There are two ways to determine prognosis. Usually we do them both in consort. There are Clark's levels, which is pretty good for determining the 5-year survival rate. And then there's Breslow's depth, which is in particular used for determining how wide we need to have our margins when we go ahead and excise this. So as you can see, the deeper it is, the worse the prognosis as far as 5-year survival. Okay, Breslow's depth is basically just how deep is this thing invading. And so we use this then to determine the margins for excision. And you don't need to memorize this at all. So further testing for melanoma is going to be based on the depth of invasion and stage. You don't need to know how to stage these. It may include an investigation of potential metastases, so all the things that you would normally do for any kind of cancer that you're looking for metastasis. Don't worry about this for exam purposes. The treatment is a wide local excision, and like I said, the dimensions of the excision really depend on the depth of invasion, that Breslow's depth. There are, if you're getting into stage 3, stage 4 melanoma, there are chemotherapeutics that are available, but this is not something that you need to know about, so I'm not even going to go into it. Stage 4 malignant melanoma has about a median survival of 6 months, so pretty grim prognosis if this progresses too much. Thankfully, most cases are detected fairly early. Primary prevention, avoid overexposure to the sun, always wear sunscreen, and by that I mean broad spectrum, which covers UVA and UVB, and it should be an SPF of more than 30. Wide-brimmed hats can be useful, if you want to wear a cowboy hat or something like that. Self-checks are good, especially in people who have a lot of nevi to begin with. These are patients you'll want to tell to do self-checks. If they've got a partner who can look at them, because, it's kind of hard to check your back, then that's great too. This is President Jimmy Carter, 39th President of the United States. He was diagnosed with metastatic melanoma in 2015, and as a matter of fact, it had spread to his liver and to his brain. He went on Keytruda, which is pembrolizumab, and is still alive to this day. I believe he just broke his hip, but is doing really well and is very active. I just saw him on the Stephen Colbert show a few months ago. So very good man, does a lot of good work with Habitat for Humanity and stuff like that. So just to recap, melanoma is a malignant neoplasm of melanocytes which normally reside in or around the stratum basale. Malignant cells usually migrate horizontally and then vertically, exception being the nodular melanoma. Classic patient is a fair-skinned person with chronic sun exposure. Going back to Jimmy Carter, he's a peanut farmer, so that's probably where he got most of his exposure. People with history of sunburns who have a lot of moles and a history of skin cancers in their family. Physical exam diagnosis, remember the ABCDE mnemonic. Definitive diagnosis of biopsy, which will show pale staining melanocytes nesting in places that they don't belong. And by that, I mean more superficial layers of the dermis as it spreads horizontally, and then ultimately the dermis as it spreads vertically. Prognosis is directly tied inverse to the depth of the invasion. And the treatment is wide local excision. The exact parameters depend on the depth of the invasion, and chemo exists, but you're not responsible for this. And that's all I've got for you for malignant melanoma. If you have any questions, please write me a note below. Otherwise, I will talk to you next time.